Hello, my name is Amelia Reha, and I'm the Quality Care Director at North Alabama Community Care. I want to thank you for taking the time to join us for our Quarter 4 medical management meeting. After many hurdles, we were able to put this together. However, at the time of this recording, the accompanying visuals are waiting to be approved. When the PowerPoint has been approved, I'll send it out. Just a quick housekeeping item. After you've watched the video, you will need to email me an attestation. You must include a statement confirming that your practice has watched the video. You'll need to include the names and credentials, so an MD, DO, PA, or CRNP of those that watched, and your practice name. My email is Amelia, that's Amelia Reha, Hreha, at northalcc.org. You will receive an email back from me confirming receipt. If you do not receive an email back from me by the next business day, please call me at 615-785-3323. That's my cell, so you may text as well. Likewise, if you have any questions regarding quality, cost effectiveness, provider participation, and so on, please feel free to reach out. If there's another question you have and I don't know the answer, I can at least direct you to the right place. All right, so let's get started. NAC's Medical Director, Dr. Debbie Redmond Hyder, will be discussing childhood obesity today. While I know that many of you do not see children, some of this information can be applied to adults as well. Additionally, you do see parents, and those parents may have children who are struggling with weight. Oftentimes, when the children are experiencing weight issues, the parents are as well. When it comes to children, a healthy lifestyle is a family journey. So while the focus today is on children, it impacts the family unit, adults included. Here's Dr. Debbie Redmond Hyder.
Hello. I'd like to take a few minutes and discuss pediatric obesity with you. My discussion will involve the following: defining pediatric obesity, causes and risk factors, health consequences, prevention and treatment strategies, along with the future direction and research. Did you know in June of 2012, the American Medical Association declared childhood obesity as a disease? This is now a growing global problem with no clear-cut treatment plan. Let's define pediatric obesity. Our criteria for diagnosing pediatric obesity is based on BMI. Those children who have a BMI at or above the 95th percentile are classified as obese. This allows us to do early identification with intervention. Prevalence and statistical trends show that childhood obesity rates have increased significantly worldwide as well as in the state of Alabama. Analyzing these trends will allow us to see the magnitude and the urgency to treat this problem. We all have misconceptions regarding obesity. We think it's a willpower issue, when it's not. There are genetic influences, environmental factors, and behavioral causes for the weight gain. Okay, so let's talk about causes and risk factors. Genetic and biological influences play a significant role in the development of obesity. Sometimes we can inherit genetic traits which increase our risk. Sometimes our metabolic rate and hormone regulation influence our weight gain. And there's also the early life biological factors. When it comes to environment and lifestyle contributors, we have to remember that our sedentary behavior, sitting around watching TV, can lead to weight gain, along with our high-calorie diets, picking up fast food on a regular basis. We also need safe places and spaces where we can go out and exercise and have physical activity. And if that is unavailable, that contributes. We also need to remember that we have to educate our children on the availability of nutritious foods, and this will help to prevent obesity. Social, economical, and cultural factors also play a role. Sometimes the lower income families face challenges in accessing healthy foods and safe exercise space. Culturally, certain foods are not the best for us. Health consequences of pediatric obesity. Short-term effects can include high blood pressure, insulin resistance, and low self-esteem and depression. The long-term effects is increased chronic health condition, type 2 diabetes, and cardiovascular disease in adulthood. There is also known to be a higher occurrence of certain cancers among adults who have a history of pediatric obesity. The social and emotional implications include the social stigma and bullying, emotional distress that they face during these social challenges can cause a negative effect on their mental health. Emotional and social disturbances also impair their academic performances, which once again can lead to social isolation. When we look at prevention and treatment strategies, the earlier we start, the better. Healthy eating habits, a balanced, regular diet, along with regular physical activity, is of significant importance. We also need to have family, school, and community engagement. There should be no TV during our meal times. We should have an appropriate diet while at school. And our community can help to foster a healthy lifestyle for our children. Once again, we need medical treatment as far as intervention, psychological counseling for the emotional stress, but a holistic approach of combining both medical and psychological approaches is best for the child. Our future direction and research should include genetics, behavioral study, and technology-based intervention. All of this to promote healthy eating habits. We should have policy changes and public initiatives for a healthier school meals, encouraging more physical activity both at school and at home, and reevaluation of the food marketing. Challenges and opportunities that we will face include the disparities in healthcare, the limited resources, when it comes to managing pediatric obesity effectively. And we need to incorporate new strategies and technology for our children. We can work in collaboration with several organizations to help foster more effective pediatric obesity interventions. In conclusion, pediatric obesity involves multiple factors requiring a comprehensive multidisciplinary approach. Education and prevention efforts are vital to reducing the incidence of pediatric obesity. To improve the health outcome for our children, we need to combine treatment with supportive policies. After our discussion, our overall goals should be to develop healthy habits and lifestyles for our children, to improve their health and quality of life, as well as their body composition. We should try to prevent any future adverse health consequences, and this will lead to an improvement in their body image and self-esteem, which is important to their future development. Thank you, and let's move forward together.
Thank you, Dr. Redmond Hyder. So if anyone watching has any questions for Dr. Redmond Hyder, please email me directly or call, text. I'll be sure to get them to her. So now on to quality. Beginning on October 1st of 2024, the quality measures changed for providers and for NAC. So we're 1 year into the new measures. For providers, there are 3 adult measures and 5 child measures. However, there are a few crossovers, as I'll explain. So even if you only see children or you only see adults, there may be some crossover here, as I'll go over. For adults, this includes chlamydia screening in women aged 21 to 24, HbA1c control for patients with diabetes, and that is considered greater than 8% for ages 18 to 75. And lastly, postpartum care. Now, this is considered an adult measure, but it includes all ages. So for children, this includes chlamydia screening in women aged 16 to 20. And even though this is a child measure, it includes women aged 18 to 20. So even if you only see adults, as in 18 and up, this would still apply to your practice. Childhood immunization status, that's a combination of DTaP, IPV, MMR, Hep B, VZV, and PCV. Now, please note that we've not received any updates regarding changes to immunization requirements. Therefore, until we're notified of a change, these immunizations will still stand. And lastly, well care visits for children and adolescents. Now, this is divided into ages 3-11 and ages 12 to 17. It should be noted that the Alabama Medicaid Agency is reporting well visit data for those aged 18 to 21 as well to CMS. It's just not a part of the quality bonus calculations. So where did these measures come from? All measures are developed by the National Committee for Quality Assurance, also known as the NCQA. Subsequently, the NCQA child measures are largely based on the American Academy of Pediatrics Bright Futures. The Centers for Medicare and Medicaid Services, also known as CMS, selected numerous adult and child core measures that each state is to be measured on. The Alabama Medicaid Agency was then tasked with choosing measures that best fit the needs of our population in a pay-for-quality system. For each of these measures, there are targets you should be focused on reaching. I'll be sending out a link to this information later. The Alabama Medicaid Agency has several PowerPoint presentations and videos that do a great job explaining how quality measurements and cost effectiveness work in the ACHN model. This next point is very important. Right now, you're receiving quality bonus payments automatically and not based on meeting your targets. The payment is based solely on the number of recipients attributed to you. Beginning April 2026, this will change, and you must meet the annual bonus benchmarks in order to receive the bonus payment. Also, the data is based on a 12-month rolling period with a 9-month rollout. So if you count 9 months ago from today, it would be based on the outcomes that occurred in the 12 months before that. At the time of this recording, we're in September 2025. So 9 months prior would be January 2025. The data would be based on the preceding 12 months, which would be January to December of 2024. It is rolling, so the information pulled in October 2025 would be based on February of 24 to January of 25, and so on. Another way to look at it is you're being measured on your practice's outcomes from 10 through 21 months ago. This is why it's paramount to jump on this now if you haven't already. Come April 2026, the measure should be based on your outcomes from July of 24 to June 25, give or take a month. I'll defer to Medicaid to confirm, but it should be around that time frame. Like I said earlier, NAC has quality measures to meet as well in order to receive the pay for quality payments. Again, there's some crossover between child and adult measures. NAC and the other ACHN regions have 6 child measures and 6 adult measures. For the children, this includes contraceptive care for women aged 15 to 20. This measures moderately effective methods and long-acting reversible methods. developmental screening in the first 3 years of life, well-child visits in the first 30 months of life, weight assessment and counseling for nutrition and physical activity, live births weighing less than 2,500 grams, and lastly, timeliness of prenatal care. Even though this is in the child core measure category, all ages are included. For adults, this includes breast cancer screening, contraceptive care for women aged 21 to 44. Again, this measures moderately effective methods and long-acting reversible methods. Follow-up after hospitalization for mental illness. There are 2 measures, within 7 days and within 30 days. Follow-up after an emergency department visit for mental illness. Again, 2 measures, within 7 days and within 30 days. Initiation and engagement of substance use disorder treatment. 2 measures here. Initiation should be within 14 days of the diagnosis, and engagement should be within 34 days of the initiation. And lastly, the use of pharmacotherapy for opioid use disorder. So these are the quality measures that NAC is tasked with targeting. Of course, we do need your help. Referrals to NAC are one of the best ways to help so that we can work one-on-one with your patients. Moving on, I'd like to note that we have submitted new quality improvement projects to the Alabama Medicaid Agency for review. Once these are finalized, we'll present them at the following medical management meetings. The quality improvement projects still surround the same topics: childhood obesity, adverse birth outcomes, and substance use disorder. Some of the projects were kept, some terminated, and some had changes made in effort to improve outcomes. Hopefully we'll get a response soon and can share those with you. All right, that wraps up this meeting. Please don't forget to email me your attestation, and as always, please reach out with any questions. Thank you.